Hello, everybody. Greetings from Pathkind and Heart Care Foundation of India and MedTalks. मैं हूँ Dr. K. Agarwal, President, Heart Care Foundation of India. Welcome to our fifth non-stop Pathkind seminar. For me, it is 1557th non-stop COVID seminar, which I am moderating. The topic for today is when and how should asymptomatic be tested. Today, we have reached a stage where we are almost in a curve which is falling, falling, and falling. We are absolutely late May situation. Number of cases have gone down. And at this moment, people are going to become more easy. They are going to relax in their precautions. Therefore, we need to shift our strategy. We still don't want another curve to come. We are still saying Kerala is still not in a good situation. So we have to pick up asymptomatic cases because we know that for every one symptomatic case, there are 10 to 30 asymptomatic cases. I would go to the number of 30. So when the number of cases in the city as a whole are low, you will have more asymptomatic cases, which will go on transmitting the infection to the society. If you want to cover up and if you want to finish COVID infection from the society, which I'm sure India will be in Southeast Asia will be the first one to get rid of the infection compared to the West, as we have seen in SARS and MERS. We need to pick up cases who are asymptomatic. ICMR need to change, India need to change, the diagnostic need to change, the way we test need to change, like in dengue, IgM need to come back, which so far has not been of importance. We are only giving importance to IgG total, IgG, IgM total. Let's listen from the horse's mouth. My colleague, Professor Ashok Ratan, who is an advisor to the Knowledge Forum R&D and quality of Pathkind's labs, who has been giving you on a weekly basis all about diagnostics. A Commonwealth Fellow, formerly in the faculty of All India Institute of Medical Sciences. He is a INSA DFG Fellow. He is a CRO temporary advisor, and he is a WHO Lab Director, CAREC and PAHO. Let's listen to him, and then we will interact. Over to you.
Thank you, sir. Good afternoon. I'll just share my... So today we deal with when and how should asymptomatic be tested for SARS-CoV-2 infection to help stop the spread. We know that when the first epidemiology and clinical characteristics of COVID infection were described, it was mentioned that there is fever, there is cough, and there's shortness of breath. Soon, CDC added new symptoms and indicated that a clinical diagnosis should be entertained if there's cough and shortness of breath, or at least two of the following. That means fever, chills, repeated shivering, muscular pain, headache, sore throat, diarrhea, and of course, it was noticed that new loss of taste or smell occurred a couple of days earlier than other symptoms. And the dynamics of clinical symptoms were described. To control this, various strategies were used. In China, they had lockdown and internal internal travel was severely curtailed within China, but people were allowed to move out from Wuhan to different parts of the country and to different parts of the world, and they spread the infection from there. We use test, trace, and treat, that is, isolate of symptomatics as listed above. There was also, ICMR must be congratulated for rapidly ramping up the diagnostic ability. In January, there was only one lab, that is NIV Pune, which could diagnose COVID infection. And now we have 2,362 labs which can do the function. Some of them in the private sector, but many of them in the government sector. We have tested using nucleic acid amplification test. Different tests are available now. The rapid antigen test as well as sero surveys have been used, and the latest sero survey in India, in Delhi, indicates that about 50% of Delhi citizens are already positive. Even for traveling from one place to another, we need a negative certificate. And of course, the vaccines have also been introduced now, and many persons have taken vaccines, including both of us. What you need to see is that SARS, that coronaviruses, there have been 3 coronaviruses out of the 7 which have jumped from animals to human beings, and then 3 of them have caused severe infection. But SARS-CoV, which appeared in 2003 and lasted for only a few months, caused 8,000 infections and 700 odd deaths. But SARS-CoV-2, which appeared in 2019, has caused now hundreds million cases, confirmed cases, with 2 million deaths. Now, when SARS came, we used symptom-based approach, and then there was subsequent testing to guide isolation and quarantine. The same strategy was initially employed to contain SARS-CoV-2, which had worked very successfully for SARS-CoV-1. But as you've seen, this is spreading relentlessly. Now, we know that SARS-CoV-2 can be symptomatic or asymptomatic. In symptomatic, it is divided into mild, moderate, severe, and critical. In asymptomatic, if we follow for another 7 days, then many of them show symptoms. So at the time of testing, they are negative, they don't have symptoms, but within 7 days, they will show symptoms. Those will be 80%. Those are known as pre-symptomatic. But at least 20% will not show any symptoms at all. Now, the definition which was used in China was that the definition of asymptomatic patient would be a person who's positive for SARS-CoV-2 RT-PCR, but has no clinical symptoms of signs and no apparent abnormalities on imaging, including lung CT. This would be the definition of asymptomatic patients. Using this definition, they found that asymptomatics were also infectious, and Gao has reviewed this in March and indicated that in China, maybe 1.6% were asymptomatic, but In Washington, DC, 56% were asymptomatic. But of course, the numbers were different. So, but they indicated that there was a wide range of persons who were asymptomatic. Recently, from Canada, there's been another systematic review and indicated that there is the relative risk of transmission from asymptomatic might be less than from symptomatic. Of course, in between, WHO suggested that there was no risk from asymptomatics and they need not be, and CDC went around and said that they should not be tested. Now, after this, there have been reversal of their suggestions, and it has been found that yes, there is asymptomatics cause less transmission than persons with symptoms, but there is relative risk of transmission from asymptomatics. Again, reviewing many cases, you would find that asymptomatics will cause infection, which would be severe, which would vary from non-critical to critical. So just because the person was asymptomatic does not mean that secondary infections will not be severe. And in many of the cases, asymptomatic at this point might become pre-symptomatic. When they analyzed asymptomatics in greater detail, they found that the RT-PCR has to be positive, but the CT values were nearly the same between symptomatics and asymptomatics. There was not much difference in the CT values, and that the excretion of the virus was for longer duration than when a person is symptomatic. In antibodies, the antibody titer was slightly lower, both for IgG and IgM, and the neutralizing antibodies would decrease sooner than in symptomatic. Another study from USA indicated that whether you look at Asians, blacks, whites, Hispanics, Latinos, or anybody else, you would find that the viral load in symptomatics and asymptomatics was similar. There was then an outbreak which was investigated in Old Here nursing facility in which persons had died. But by that time, they were already isolating symptomatics, and they found that it was pre-symptomatic staff which was transmitting the infection. And Monica Gandhi indicated that asymptomatic transmission was the Achilles heel of current strategies to control COVID-19. We already know that RT-PCR is inadequate to diagnose even symptomatic patients. And Liu was the first one to indicate that at best of time, RT-PCR would detect 80% of cases. If you wanted 100% diagnosis of symptomatic cases, you have to add serology to it. Gao also had similar kind of experience that if you, in symptomatic patients, if you use only RT-PCR, you would diagnose less. If you add serology, it will be more. Even in Boston, Miller made sure that all patients admitted with symptoms of COVID were tested not only by RT-PCR, but also by serology. Though serology started playing a role after 9 days. So when we come to asymptomatic, we should be clear in our mind that here we are not going to use only diagnostic tests. And for asymptomatics, when to test, it becomes a screening test. And the screening test would be different than only the diagnostic test, and the sensitivity and specificity of a diagnostic test may be different in a screening test. One of the attributes of a screening test must be must give quick results, and it should have high sensitivity. While for a diagnostic test, you need high sensitivity, yes, but also high specificity. And of course, cost is always a factor when you're going to do many tests. So Liu then indicated a study of asymptomatic patients. In that, they also studied equal number of persons with mild infection and close healthy contacts. And they noticed, this is a summary of their report, that if they took asymptomatic patients, NAT was positive in 12. So our definition initially was that asymptomatic is NAT positive. So instead of 63, then it will be 12 positive. And NAT negative was 51. But in those asymptomatic patients, they had, when they look at IgG and IgM, 23 of them had IgG and IgM positive, and another 28 of them had IgG positive and IgM negative. So they indicated that if you add IgM, and by microarray, they found that persons react to only S1 and N, and IgM to S1 would indicate recent infection. It starts by 7th day, reaches a peak by about 15 days, and then starts declining. So that the period that we felt was infectious or asymptomatic was excreting virus, you would have higher IgM against spike protein. Neutralizing antibodies in asymptomatics were less. As they indicated here, if you do only NAT testing, you would get only 4. And along with IgG, you will get 8. But if you add IgM to it, then in asymptomatics, you would stand to gain some more cases. And so would be the same in case with mild infection. Neutralizing antibodies are less in asymptomatics than in mild cases. And the dynamics was such that IgM was detectable by 7th day, with peak by 15 to 25 days and then decline. And this was S1 IgM, while IgG against the N protein would last for much longer, so may not be indicator of new infection. So on the basis of the results that they got, on the basis of the results that they got, they said that if you are looking only at NAT, then you would only pick up 19 of those persons who are infected, and 81 of persons who are infected as a consequence being close to infected patients would be missed. Asymptomatics would be missed if you rely only on nucleic acid testing. But if we add IgM antibodies to S1 proteins, then we would be able to pick up more. And they suggested that there should be modification of the definition of asymptomatic infections, and it should be redefined as a person who's NAT and or IgM antibody positive without clinical symptoms and radiological changes. And they recommended that either both NAT and S1 specific IgM should be used for identification of infectious patients, or we could screen with only antibodies, and in case it is positive, then the person should be quarantined. This way, we would discover another 51 additional asymptomatic and 17.6 additional mild infections, which we would have missed had we used only NAT testing to be done. Serology could also be used to link up, and this is what had happened in in Singapore, where there were two outbreaks in two churches which were not being linked. Only when serology was used, they found that A2 had a family meeting in which F1 was the second one who was infected. And so if you rely only on NAT testing, you will miss the connection. It was only when serology was added that A2 and F1 were linked together, and the link between two churches outbreaks in two churches were established in Singapore. Similarly, if you have a large number of persons in the hospital and you want to inquire, you want to ensure that the hospital runs, then instead of NAT testing, it should better to screen with serological testing, and only if a person is positive, then NAT should be added to find out whether it's a recent conversion. Again, whether a person needs to go back to work or not, serology would answer that. And to make sure that a false positive reaction is not indicated, it would mean that we should do, CDC indicates that we should do orthogonal testing. Orthogonal testing means two separate testing. So first test is to indicate whether we have exposure. This will use nucleocapsid protein, which is the most immunogenic antigen, and look for all types of antibodies. So total antibody. If it is positive, then we can go in for whether we have protection, and we know that the protection is as a consequence of antibodies against spike protein. Again, before surgery or delivery, it is best to do antibodies. And if antibodies are positive, then we can go ahead and do the surgery and not do anything else. If not do anything else in between while the patient is in the hospital. If on the other hand, PCR is positive, then we should postpone the surgery. If both are negative, we can still go on and do the surgery. Thyrocare had shared the results of their serosurveillance, which on asymptomatic patients, which would indicate what was the prevalence of spread of infection. This was done on 24th July after about 50,000 tests. Then subsequently on 9th September, they had shared the data again after doing 4.5 lakh tests, and they had reported that in Dharawai, 50% of persons were already having antibodies. Similar studies have now been done in Delhi by ILBS, and they also find that 50% of persons in Delhi are having antibodies. It's also been seen that recovery of the persons who recover from mild infection have mild antibodies. So their immune response is different than after suffering from infection than those who have severe infection. And in our own study, we found that persons with antibodies against nucleocapsid protein or against spike protein, the antibodies were of low titers, and persons over 1000 antibody titer as arbitrary titer was only 2 out of the thousands that we tested. We agree that neutralizing antibodies are the most important antibody to demonstrate. But since this cannot be done unless we have a BSL-3 lab or we have a pseudovirus, a new test which I described last time was using ACE2 receptors, which is genetically engineered, along with using RBD. And the advantage of this is that if there are mutations in RBD, receptor binding domain, then new receptor binding domains can be made, reflecting what is happening in South Africa or in Brazil or in UK, and we can look for neutralizing antibodies. At this moment, we have one with the wild strain at the. Now, this has correlated very well in China as well as in Singapore with protection. We also know that now the two vaccines which have been available, they produced high titers of neutralizing antibodies. After the first dose, the mean titer is about 8,000. As I showed you, after recovery, the titer is less than 1,000 in majority of patients. But after one dose of the vaccine, on 20th day after the vaccine, the titers are in the range of 8,000. And after the second dose, the titers become around 29,000. It was also noticed that if there is a longer distance between between the booster dose, then the titers may even go up to 63,000. Similar case was also found in Covaxin. Covaxin also produces high titers. Along with high titers, it produces neutralizing antibodies, and it also has cell-mediated immunity. So it would appear that persons who undergo 2 doses of vaccination would produce antibody titers much higher than if they've suffered from infection and recovered. And so that is why we are making the request that those who undergo 2 doses, 14 days after the second dose, they should get their neutralizing antibody tested. And if it is more than 1,000, they should donate their plasma, because it's been shown that this is beneficial for those elderly persons who might not have undergone the vaccination, and if it is given within 72 hours of appearance of symptoms. So finally, I would say that if it is asymptomatic transmission, which is the Achilles heel of current strategy to control COVID, we need to change our definition and our method of detecting asymptomatic infections. It's not only the test that matters, but the strategy, whether it will be target testing, how frequently would you test and whom would you test, and individual behavior, because these antibodies will protect us but not be sterilizing. We should continue to use masking, social distancing, hand hygiene, and practice cough etiquette. And this way we'll be able to diagnose the asymptomatic patients. So now we can take up questions if there are any. You're mute, sir.
Well explained discussion. So my first thing is that something strange we are seeing, and that is UK, South African, and Brazil virus is not liking the Indian blood so far. We are not, the cases came and they went. The spike hasn't come, which is occurring of UK virus in other strains. Do you think that you said that in MERS and SARS, the S gene was similar, but the RBD was different?
Yes, sir.
So do you feel that this South African strain RBD mutation and the Brazil RBD mutation has changed the virus in such a way that it is not coming into Southeast Asia? something like SARS and the MERS never came? Can we find out? Can we find out the differences that the RBD of the current RBD of UK strain, South African strain, or Brazil strain, does it match more like MERS or SARS?
No, sir. It will be different because the RBD of SARS-2 is now having changed. The changes are only 14 changes are there in South Africa.
RBM has only 70 amino acids. So if we can find out, say for example, in South Africa, we have a RBM change, two RBD changes. Maybe I'm only trying to find out that something which mutation, which was the mutation in SARS and MERS, which never allowed it to establish itself in India or rest of the world.
I think it was also seen that the N501Y change that has occurred, if instead of N501Y change, if it was N501D, then it would have been it would have gone back to the um, bat virus, which had no affinity for ACE2 receptors, and then the virus would have shut itself off. So instead of the mutation, so it depends upon the mutation that occurs and whether it's attaching.
Why can't they experimentally produce N501D in the lab?
That was already in that is what you'll find in case of bat virus. So
coming back to IgM, why we are not developing isolated IgM surveys? Why we are still believing on a total survey of IgM and IgG, like in dengue and others? Why government is not allowing independent isolated S-IgM test?
IgM would be helpful for making a diagnosis of current infection.
No. As we are talking about IgM, S-IgM and antibodies in asymptomatic cases for screening. So we are testing what IgM we are testing and how?
So, of course, what had happened, I think, in the past was that they had the lateral flow where they were looking for both IgM and IgM and IgG, and since that did not work well because it was positioned wrongly, it was positioned initially to make a diagnosis instead of RT-PCR. That was the time when RT-PCR kits were in short supply, so they tried to say that in hot spots you should use this lateral flow, but lateral flow is not a very sensitive test. What we are now using are chemiluminescence tests, which will detect very small quantity. ELISA is not people have used ELISA, and it's been made in India itself using whole virus, but manual ELISA is not a reproducible test. It's good for crude estimation, but for real estimation, an automated chemiluminescence test would be much better, which is now available, and that would indicate in a reproducible manner. It will indicate whether a person has IgM or not. And I think it was
currently what test we are doing? Currently we are doing IgG or total?
We are doing IgG, IgM, and IgG. We are doing total, sir. Total against nucleocapsid, and IgG against spike protein. Then Disorin has now introduced a trimeric. They have, instead of S1, S2, they made a trimeric antigen, spike protein antigen, because in a study where they used monoclonal antibodies and then tried to find neutralizing antibodies, they found that when you trace the where the neutralizing monoclonal antibodies bind, there are 9 receptors on RBD, 8 receptors on S1, and 2 receptors on the top, which will neutralize the spike protein which will prevent it from binding the ACE2 receptors. So there are about 19 sites on the spike which can be neutralized by monoclonal antibodies, and the activity of spike protein be blocked from binding the
No, what I'm
ACE2
asking is,
receptor.
how are we testing IgM to S1 IgM today?
S1 IgM is available as chemiluminescence. There
As
are two
an,
chemiluminescence is available
as an independent test?
as an independent test.
Not a
It's
part
from
of
Abbott,
not a part of the total antibodies.
not part of total
So
antibodies.
that has been introduced now. That means
That is available. Yes,
so
sir.
now we can ask for IgM and IgG separately.
IgM can be asked separately. IgG can be separate.
Earlier government has banned IgM.
So that was banned because of lateral flow, and the persons depending upon lateral flow for making a
So the message
diagnosis
for today is that IgM now is introduced, is available.
is aware. Yes,
That
that is
then it makes very easy because everybody knows the importance of IgM. M and G. M means I am there. G means I am gone. That's the way we remember. So that we always tell people to remember in any infection, go for IgM. If you have IgM positive and antigen positive
so
versus
I think this might also explain why even when they're traveling by flights, they do RT-PCR negative, and when they land up, they find that persons have got infection during flight. And I think it was only the Chinese uh, carrier which introduced that you should do IgM as well as RT-PCR negative. But somehow it did not catch on. This paper was published in August. This paper on dynamics of dynamics of antibodies in asymptomatics was published in Allergy recently in September. It was available as preprint in September. In August it was available, indicating that you would have to use IgM also along with NAT testing to be able to pick up more asymptomatic
so
persons.
how much this IgM test cost?
So cost is always being worked out. I think the
Currently, what is the cost?
about six. One of the problem has been the cost capping that people have put.
No, no.
But
What is it is if it is available, there has to be available as on today cost. Because people are listening, they may start referring you right away and after half an hour.
so, I would have to ask the marketing people about what
So,
cost
so,
it
so
will
one
be.
thing I'm trying to say is that if you are, so instead of asking two RT-PCR negative, you ask them RT-PCR negative and IgM negative.
That makes more sense, sir. That RT-PCR has, as we indicated, even in symptomatics, it was negative. It was not positive all the time, but unfortunately, it was labeled as gold standard, so it has stayed in the mind of persons, and all over it is being used. Yes, it is used. It is a very sensitive test, but maybe sometimes they say it's too sensitive a test. So
Last time we talked about introducing on 7th day total antibodies test. So will that go with this availability now?
so this if you do antibodies after 14 days, then this is to make a retrospective diagnosis. If you
No,
are detecting
after 14
IG,
days, I'm going to summarize. After 14 days, you go for S and N antibodies.
if you go for that depends on whether you're looking for IgG or IgM. If your objective
I'm
is
talking about, let me have situations. Number one, because I need to finalize this, people are watching. One is, am I recovered? Am I recovered? Post-infection, 28 days. What should I do?
post-infection, then S1 antibodies against spike protein of IgG type would indicate that you are recovered and protected.
Which will be which one? S1, S2, or primary?
Trimeric is best, but if trimeric is not available, then spike protein is fine. And because it just indicates some more, trimeric is slightly more sensitive than S1, S1, S2. But on 28th day, if you have spike protein and the titers are high, then it means that you're protected.
And what is the titer high means what?
So that has not been decided, but
Let us give an arbitrary number.
But if you are more than 15, that means you have some neutralizing antibodies.
More than 15, and it is defined as what is BAU per ml?
Sir, more than 15 AU per ml.
AU means?
Arbitrarily unit. People have now tried to say that it should be known as binding arbitrarily units. So BAU per ml should be more than 15. But if you want to donate to help somebody else, then it should be at least 1000 BAU per ml so that the other person will benefit from that, which normally is not occurring unless a person is vaccinated.
So on day 28, N has no value.
N has no value, sir.
So day 28, N has no value. Now let me come back to day 7. Day 7.
Sir, day 7 on normally days instead of day 7, day 15 is better. Okay. Because day 7 it starts appearing. And when it starts appearing, then it may be positive, maybe negative. You want to be at least 90% sure that by day 14.
Day 15, what do we test?
It again spike. If your RT-PCR negative and asymptomatic, then also it now the new evidence is indicating you should test IgM by S1.
So see, if I am having a person with who is I don't know, he is symptomatic, but I don't know his RT-PCR repeatedly is coming negative. Why should I wait for day 15? I do it on day 7.
No, for making a diagnosis, you can test anytime with looking for IgM. If IgM is positive, that means the person has recently been infected.
And now, therefore, the total antibodies now will have no role after the introduction of IgM.
Total antibodies were useful only to see whether a person has been exposed anytime. Now that means that doesn't have any diagnostic value, and in fact there may be some cross-reacting antibodies.
So the message today is the total antibodies from today onwards, in the availability of IgM, which is much more sensitive against S1, total antibody does not find any place now.
Right, sir.
Okay, except for the cost.
Yes, sir.
Except for the cost, because total antibodies still will be cheaper than the IgM specific antibody.
Yes.
So except for the cost. Then apart from that, what about post-vaccine? Which antibodies?
So post-vaccine, you want neutralizing antibodies. Of course, I was talking to one of my colleagues in ILBS, and she said that in their survey, they had used antibodies against spike, and they have also that antibodies against spike also have neutral, but that is a indirect indicator. If you want direct indicator, then the neutralizing ELISA, which is using recombinant ACE2 receptors and recombinant RBD, will give you the best test for neutralizing antibodies.
Now, if I want to know myself that I'm developing antibodies or not, I'm 7th day post-vaccination. So I have to wait for another 1 week?
So, I think the best day is on the 20th day after the first dose, where they noticed that people had in thousands and it started declining, because and that is why they gave the second booster after 28 days in case of Covishield. So Covishield, the best, if you want to do only once, then it's 2 weeks after the second dose. Because after 2 weeks after the second dose, you should consider yourself protected.
So I discussed this issue which we have been discussing, that donate your plasma after vaccination with Dr. Ganguly yesterday in my show.
Sir.
And he was of the opinion is therapeutic vaccinology. Basically, he says better will be to draw out total immunoglobulins from the blood and then give it.
Yes, sir. I 100% agree with him that pure antibodies would be best.
So he says
So,
he says technology is available. The plasma
yes,
you can draw patients pure antibodies and then give it to the person. That will be better than giving simple plasma.
yes, sir. He's 100% right in that, sir.
So that concept that after vaccination antibodies will work, we can now start propagating.
Yes, sir. Definitely they'll work, sir. And of course, I think it's only time, because if you have to, if it is in an emergency situation, it's possible for everybody to have every blood bank to have a few plasma with them, which is donated by those healthy individuals who have got themselves vaccinated. And then commercial firms will be able to purify the immunoglobulins and make that available. That might take some time, but once they are available, they'll be more stable. So Dr. Ganguly is right in that. It will be more stable, and it will be maybe the cost will be less also, because they can mass produce and it will work. So that the fear of having severe COVID will then decrease.
So how many cases in your Thermo Fisher RT-PCR in the last 1 month we have been able to see S gene target failure?
So, we have unfortunately shifted because of the costs. We have shifted to a simpler method of doing RT-PCR, and Thermo Fisher is no longer being used.
So who is
So,
using Thermo Fisher now? Then how the government is picking up UK strain?
so by sequencing, I think the method has been that 5% of 5% of all at random positive cases are
No,
being
that is a separate
submitted.
issue. That is a separate issue. But then every RT-PCR, who are that means nobody is doing S gene now?
I'm not. We were doing it. We were the first ones to use, and we used it for extensively. But in the recent past, because as you know now, the prices have really come down, and Thermo Fisher is too costly a test to use to meet those requirements.
I think they see every time there is a government move, it is you have to have a find out an answer. You can still continue Thermo Fisher at slightly higher prices by writing it as gene target failure test, which has nothing to do with what government wants. That will not be a routine test. But if you are say if you are suspecting if somebody is returning from UK, suppose,
Mhm.
or somebody who has recently returned from UK, they should go for a S gene target failure test, even if it is isolated few tests. That test should be available in the private sector. Genomic study is not an answer as on today. With there's a lot of bureaucracy in the genomic study. So I think
Yes, yes.
your S gene test should continue, and by calling it as a S gene target failure test, you can charge more money than that because it's a selective test. It's not like a routine RT-PCR.
I will convey your suggestion to the decision makers, sir, and
That is
hopefully
what I feel.
we should offer a cafeteria. I agree that we should have a cafeteria. We should do tests as per the government requirement, but give options of other tests which might have different
Suppose
meanings.
if as a clinician I want S gene target failure, where do I send? And suppose my patient is ready to pay an extra amount, I want to be very sure that I want S gene target failure test. That means I want to know it is S gene negative and other two positive. Triple positive now is a new term, triple positive or triple negative. Triple positive means UK strain is ruled out. How do I rule out a UK strain? How do I rule out a UK strain? There are people who have money who wants to be very sure because once that PM of the UK has said that UK strain may be more lethal.
Mhm.
How do I
Yes.
pick up UK strain? How will I pick up as a clinician in my private sector a UK strain? I'm not going to send private sector patients are not going for the genomic study. But if I'm specifically looking for a serious patient, I say that every serious patient on ICU on ventilator should go for a S gene target failure. 5%, they are not going 5% of, they are talking about 5% is a screening survey. But I'm saying every patient on ventilator Every patient who is immunocompromised, if he is positive, we should look for S gene target failure.
Yes.
Otherwise, how will you pick up? And then in any way, all the testing has to be available, because today is S gene target failure. Today, another mutation may come back as a N gene target failure. So you have to have availability of all the three tests in serious patients. Routine cases, I can understand. So they are everywhere. Everywhere. See, the very fact companies are coming with IgM. Why any company will come to IgM? Because IgM will not be covered under the ICMR price cap.
Mm.
IgM testing, because IgM testing will not be covered under the ICMR price cap. So innovations must come as a cafeteria approach.
Yes. Now, of course, spike is the most important because that is the one that binds to the ACE2 receptors, and mutations there would make a difference, as we've been discussing.
We have 5-7 minutes. Can you explain more about the spike? Something more about the spike. Let's understand spike has how many parts? 3?
So the spike is trimeric, 3 parts, S1, S2, and in between there's the RBD. This whole amino acid.
No. S1, S2, and RBD. This is 3.
RBD, yes, sir.
So there is no S3.
No, there's no S3. There are only S1 and
RBD.
S2, and then between them is the region which is known as RBD.
And in that region, in that RBD, there is RBM.
RBM would be in that, yes, sir. And it is this which binds to the ACE2 receptors, and then there's an enzyme which will fuse the two membranes. And as a consequence, the RNA from the virus will be able to go into the cytoplasm.
That fusion is after the RBD. The fusion place.
After touching, because touchdown, in a way, landing is by RBD binds to the ACE2 receptor. And then after that, the enzyme gets activated, which is in the cell, which will then fuse these two membranes.
No. I'm talking about what is the role of S1, S2 point junction.
That is the
virus, the amino acid 679, because 681 mutation is just at the junction of 679, which is the fusion point between S1, S2. What is the role of that fusion point?
So I think I was told that it's in 2 stages. One is as open stage and the other is closed stage. In the open stage is it is available for action against the antibodies. When it is in closed stage, when it is a folded stage, because the proteins actually have a 3-dimensional structure. In the 3-dimensional structure, if it is in the closed stage, then neutralizing antibodies may not bind. But when it attaches itself, it comes in the open stage, and this RBD will then bind to the ACE2 receptors. And when it binds to the ACE2 receptors, the membranes fuse, and the RNA is allowed to enter into the cytoplasm.
So I'm basically talking about is that why this virus should not mutate further. Why this virus should not mutate further? Because it is still one UK strain is still only one RBD mutation. South Africa has 3 RBD mutation, 1 in RBM and 2 in RBD. Therefore, UK strain is going to mutate further. Therefore, S gene 1. So all those people who are watching this program, let's summarize. Number 1 is start asking S gene target failure. Whenever you get any patient who is sick, who is immunocompromised, where you feel that the 20-day cycle is applicable. 10 days means isolation for 20 days is applicable as per the Government of India guidelines. You must ask for S gene target failure. Whether mankind is doing or not, if pathkind is not doing, somebody will do it. Do it, ask for it. If you start asking for it, because I don't find any reason S gene target failure will be done at the same cost as a routine cost, because it's a special test. So S gene target failure is one test you should ask. Second thing is, instead of total antibodies, start asking for IgM S antibodies. And depending upon on which day, you can ask it on day 1 if you are asymptomatic, because in asymptomatic, you don't know how long the patient is asymptomatic. Or you can ask on 7th day, if the patient is symptomatic, you have not been able to diagnose what it is. And if the patient has suffered from a COVID, go back to 28 days. 28 days will be applicable to both vaccine and non-vaccine. In a post-vaccine, you ask for S antibodies as a non-specific neutralizing antibodies. But if you want a specific neutralizing antibodies, you have to write down post-vaccine neutralizing antibodies test. That's a special test, and that will not be available at a cost of a simple antibodies. That will be a special test. When you are going for a plasma donation, now we have people who will be almost like 2 weeks after the vaccination. You may still find some of them developing binding antibodies. So maybe another 1 week or 2 weeks from now, you will have donors available who will be able to donate their plasma to people, a high titer plasma. Normally, they say more than 1,000 BAU, but I'm saying you may get 8,000 because that's what the studies have shown. 8,000 by day 28. And that will be much better than giving a live donor plasma, because there will be asymptomatic people who will be donating. Severely symptomatic patients will never donate the plasma because they will be sick oxygen for quite some time. These are the people who have very high titer. They will never come for a plasma donation. So that's what we wanted to say today. If you have any questions, you can pass it on to us. What are we doing next time, next Friday? What subject are we covering next Friday?
We'll think of something next. So I think we've covered most of the stages.
Next Friday, the topic will be unanswered questions. Can it be answered by serology? We'll frame some questions, unanswered questions in diagnostics. So whatever we have done till today, we will put them into one. CT value, asymptomatic, symptomatic, vaccination. So all our lectures till today, we will try to put it into one in the basis of a question answers. Only clinical case studies. What should I do? What should I do? So that the next class will be more on practicals, what to do, what not to do. That's all for today. Let me thank Professor Ashok Ratan to be here. Wonderful talking to you. And I feel all those people who are watching, you have gained something today. Namaskar.
Namaskar.